I will now move on to agenda item 8, the full service partnership report. For this agenda item, we will consider and receive adoption of a legislative report on the status of full service partnerships as mandated in the Welfare and Institutions Code, section 5845.8 of Senate Bill 465. The Commission's report aligns with and supports current efforts from DHCS and HCI to improve full-service partnerships through a range of initiatives and informs future initiatives under development. We will hear more on the specific ways this report aligns with these efforts in today's presentation. So thank you, Dr. Callie Clark, a research scientist supervisor at the Commission, on this report. We're looking forward to your presentation. Please go ahead.
Thank you so much, Madam Chair. I want to be respectful of time this afternoon. I know this report is very long and it's very detailed, and so I thank you all for taking the time to read it. But I also want to be true to my training, which is that we can't expect the public to trust us if they do not know who's doing their research. So I'm going to take 10 to 20 seconds to let you know who I am and how it informs this report. So I'm trained in social work. That's my background. I conduct large-scale quantitative analysis to bring about systems change, not at the program level, but large behemoth systems that are difficult to move. I also was trained by our Department of Education at the federal level in how to do advanced quantitative research. So I'm literally here before you because of those investments by our federal Department of Education. I'm able to do this work for the people of California because of those investments. With that said, I want to go over a little bit about, and most importantly, I'm also a family member. So I have a sister who was a longtime member of FSPs for more than a decade, for 2 of them. In fact, shout outs to Sacramento and Sutter County. Thank you for everything you've done for my family. Next, so I'm going to go over a brief bit about the past and the future of where we're going with FSPs. FSPs are the last stage of intervention in our upstream efforts to divert individuals with serious mental illness away from the negative outcomes of homelessness, incarceration, and hospitalization. Previously, they accounted for 38% of the total funding under MHSA. Now they will account for 35% of funding under BHSA. So they remain a core investment. They serve about 45,000 people a year, and over their tenure, they've served about 250,000 Californians. FSPs arrived from advocacy efforts in the early 1990s, expanded through the 2000s, and now we have a host of policy changes that will most likely change the face and the implementation of FSPs. And those include the CARE Act, CalAIM, and the trifecta, which is BH Connect, Prop 1, and behavioral health transformation. During this extended period of investment in FSPs, the Commission has been right there. We've invested equally in FSPs and understanding them and supporting them, and we've done that in 3 key ways. One is in supporting counties so that they can get their data organized and stored and do capacity building around those areas. The second is in supporting providers directly, and this includes doing quality improvement, helping them identify and track goals, and then also providing technical assistance so that they can implement that with fidelity. And then third, and what's unique, I think, is that we've built the internal capacity of the Commission to be able to tell a holistic story about our FSP clients. And we've done that by bringing in interagency data, which you will learn a little bit more about through our data warehouse. I have to tell you, the data warehouse here at the Commission, we don't speak about it enough. It is very much one of the finest I've seen in the state and quite frankly in the nation. There are so many people that would be envious of what we are able to do. Part of what we have to do is to present a report to the legislature every 2 years. In that report, we're asked to provide information on 3 key things: who is being served, the clients being served, including a demographic overview so we can get a snapshot of the state, the services that they're receiving, and including outcomes, and then also challenges that we see in receiving those data and being able to tell that story. And then lastly, our recommendations for how, what we can do to improve FSPs across the state. Before we get into the data, I want to go ahead and tell you a little bit. This slide was in your appendices, but I'm going to just go over it briefly right now. One of the reasons why we have such a difficult time telling this story with FSP data is because we're asking clinicians to collect data in in non-ideal circumstances and without giving them the proper training to be able to do so or the tools to do so. As an example, we asked them to complete 13-page intake forms with their clients, asking them to account for things such as where have you slept for the last 365 days, at the very first time they may have met someone. You can imagine that that's a difficult thing to do with someone who is in distress or may be, in fact, dealing with psychosis at the time. We also ask them to track key events in somebody's life, but we don't give them the time or the resources to do that effectively. So what happens? They end up tracking the negative outcomes because those are the most important to hand off to the next clinician. Not whether somebody got a job, but whether they lost a job. Not whether they got housing, but that they lost housing. So this means that so far we have a difficult time getting complete data and accurate data from our people on the ground. Lastly, we ask them to complete reports every 3 months on their clients. And if somebody before them did not complete a report, they are not able to complete their report. And so we have a system that has a lot of snags in it, and we are suggesting in this report ways that we can help improve that system and ensure that we get the quality data to be able to tell a good story and an accurate story about our FSP clients. The data from providers goes to the county. Then the county checks those data with providers. That takes time. Then they send it to the state. We get it from the state. Now, if we were to only rely on those data, I would not be here today giving you a very comprehensive report. My report would simply say, I can't tell you this story because we don't have very good data. But we at the Commission have a data warehouse where we bring in data from other agencies and departments, and we can fill in a lot of those gaps for our FSP clients. We have so much data in the data warehouse. We use just a few of those for our report in here today, so I want to touch on them. HCI data, so we understand hospitalization. We have client services information, which we rely on heavily. Things like Department of Education data. We anticipated having Department of Justice data. We are finishing up that DUA now, and we will have those for the next report. Our next report, if things go well and the report is adopted and the implementations that we suggest are taken up and we all undertake this call and see systems change, our next report in 2026 should look very different. And we're working to ensure that it does. So we are bringing in Medi-Cal data, including drug Medi-Cal data, and we also have our Department of Justice data so we can tell a more holistic story about arrests and recidivism for our clients, but also be able to tell a comprehensive story around SUDs, which is critical because in 2026 we will have eligibility changes for FSPs. And therefore, we will be able to speak to individuals who are now FSP clients under those primary eligibility requirements of SUD. We do a lot with our quantitative data, but we do not stop there. The researchers here at the Commission very much value the voice of individuals impacted and affected by the work we do. So we did a lot. We hosted public panels, we solicited feedback from commissioners, from staff at agency, DHCS, legislative staff, and county behavioral health staff, in fact, 186 of them. And then we also posted our executive summary online to get public feedback. We did targeted outreach, community forums, statewide survey, and then we also did 3 deep dives into counties, 2 case studies, 2 pilot projects, and 4 site visits. We have information there, a little bit of information on some of the demographics of people who participated in those. There's more and further breakdown in the report if you're interested. But we worked very hard to be able to reach people at all levels of the continuum and bring their voices to the table for this. All of that together, when we write a report, we don't look to any singular learning or any singular element to tell a story. We have to see it in multiple places. So we call that triangulation. So if something was seen in the quantitative data, we want to see it in the case study. If something's seen in the case study, we also want to see it in a focus group. Together, then, we tell a comprehensive story. And some of the descriptives that we can tell about our clients is that we know that more than half of them are children in TAYs. We know that 60% of our homeless clients and about 30% of our child TAY clients of our adult clients and 30% of our child TAY clients have reported being homeless currently or in the past at some given time. We know that a year and a half after joining an FSP, 2/3 of our child and TAY clients have moved on and exited. And that's significantly more than our adult clients where we're looking at under 40%. When we look at why they've moved on, we do see for our child and TAY clients that about half of them have moved on because they met their goals, their stated goals, which is the most ideal situation. But that's substantially larger than what we see for our adult clients. We also can tell a story about service usage. So we looked at crisis services, psychiatric admissions, and hospital inpatient days. 3 key areas. This is not fancy quantitative analysis. We can see it right there, smack on the page, what has happened. We compared the year before people joined an FSP to the year after they joined an FSP. And what we saw is that crisis service usage was reduced by almost 16,000. Psychiatric admissions were reduced by by more than 27,000, and that equated to 250,000 less inpatient hospital days over the existence of FSPs. If you take the cost of a single hospital day and you look at how many we've had a reduction, that's a significant amount of money. All of the points that I brought to you today come together for us to be able to give some recommendations for what we need to do to see very large system change. And this is a big lift, but we also lay out very clearly in the report how we believe it can be done. The first one is around data collection and reporting. We first and foremost need to get that system in check so that we can speak well about our FSP clients, and our service providers can, and the county can. We can't wait until it gets to us to clean it up. We need to have good data from the beginning. So we are suggesting an overhaul of the DCR system. We know it has substantial issues, and in order for providers to meet the call of Prop 1 as far as transparency and data reporting go, we need to see that overhaul. We recommend replacing the DCR with something that's more efficient, effective, and accurate, and we go into very detail what that would look like and use the voices of individuals who use it in the report to help illustrate that. DHCS is currently planning an overhaul of the DCR, and we are delighted to hear such. We believe that this report can serve as a valuable resource in guiding those efforts. The second key area is around staffing and workforce. Staffing and workforce challenges are not new to anyone. We know that they're there, but we do have some recommendations for how those can be lessened. One is about widening the pipeline, so building relationships with local universities in developing internships, programs specifically tailored towards individuals working in FSPs. We would like to see increased incentives and benefits that provide financial resources to counties to supplement wages in areas that are most struggling to fill positions, and offer workforce incentives like subsidized housing, loan repayment, or paid internships. We're recommending reducing provider stress. That sounds really large, but we suggest that it can be done by developing trainees in specific high-stress areas that providers have told us directly, such as around billing, documentation and data entry, housing services, and services for individuals with SUDs. And then lastly, we recommend better utilizing peers and investing in expanding peer certification and placement programs, including licensing, training, and post-placement supports. Peers are more than a workforce solution. They're a key to increasing client retention and ultimately improving outcomes. We also have some recommendations around performance management. We found that most providers lack systematic goal setting and tracking abilities. And there's insufficient incentives to provide for reaching client-specified goals. We suggest incorporating performance metrics into contracts, better incorporating them with service providers. And we suggest launching a statewide learning community on performance management. Performance management may sound new. It's been around for a very long time. All it means is that we help providers identify key focus areas and the supports needed to improve in those key focus areas. So for instance, if you're a provider and you're working at 150% capacity and you're tired and you're exhausted and somebody comes to you and they say, you know, we're going to implement this new performance management to track and see how you're doing, that doesn't feel great, does it? But I will tell you, nobody should be working at 150% capacity. So what performance management does is it says, you can't do everything. Let's identify what is key right now, what is the most important. Let's focus on those. Let's get you the supports you need to improve in those areas. And once you have, let's go on and focus on new areas. It's meant to reduce provider stress and increase outcomes for clients. And then lastly, we suggest a comprehensive evaluation of the plausible impact and resources needed to create a scalable performance management statewide. Technical assistance. So we heard from providers that they really would like stronger technical assistance around funding and service models. Counties and providers both need support and clarity around BHSA requirements. And we suggest expanding technical assistance and training on the impacts of BHA. DHCS and HMA are establishing centers of excellence in key areas under BH Connect. And we're working to ensure alignment with these key areas in our efforts, but we would like to see them FSP specific. So what's on the horizon for us? So we've brought to you a lot that we have done in our recommendations, but we still have work that's ongoing. We're currently running 2 pilot programs in Sacramento and Nevada counties on performance management. I was at a recent meeting where providers spoke about their experiences, and they were overwhelmingly positive. It was a great experience to hear them talk about it. We hope to bring you the results of those in this summer. We also have $20 million in MHWA funds that are set aside to improve outcomes and service delivery. 10 million of those were specifically set aside by the Commission around technical assistance and capacity building for performance management and outcome-based contracting and service provisions. We will bring to you a more outlined RFA in May with regards to that. We have an FSP toolkit, which is underway. We worked with DHCS and HMA to identify key chapters in this toolkit so we can put resources in the hands of providers right now so they no longer have to wait for supports. Those chapters are peer and paraprofessional supports, services and treatments for individuals with SUDs, collaboration and community partners, step-down levels of support, and outreach and engagement. And then lastly, we would like to conduct the work that we've done now, but take a particular lens looking at child FSPs. More than half of our FSP clients are children, and yet we cannot speak to them very clearly and accurately. How do they differ? What type of services are they receiving? Could they be better served through other services? We have no idea. So those are just a few things that we have on the horizon, but we bring you this report as a first step in acknowledging where we need to be and what we need to do in order to bring the systems change so that we can continue to see improvements. Now, I know that I just went over a lot, and I know I spoke at length about systems and improving systems, and I want to make clear that my dedication and our team's dedication to this does include the voice of the individual. So if you read the report, you will hear the voices of so many that went into making this report. And I want to share with you, a lot of you don't know this, but my sister was a member of an FSP for more than a decade. She recently passed, and I was able to talk with her before she passed about her experience in receiving FSP services. And I'd like to share with you just a small sample of what she told me. She said, "They praise me and they tell me how appreciative I am. They recognize my qualities that I've gained in the last 10 years and that I'm of value to people. Things are pretty tough, but we're really happy. You know, we want to live independently. They've helped so much. They keep me right with my appointments and my shots, like the last time I didn't have insurance with the county set up when we moved. My FSP basically showed up and they carried me. They got me to my appointments as much as they could. It must take a lot of heart to work there, and I feel very lucky to have my FSP people." Those are the words of my sister, Marnette Clark. So I am delighted to bring you this report, and I hope that I'm able to answer all the questions that you may have of it. I believe very strongly in the recommendations that we have, and I'm here to answer anything to help you feel better in the recommendations as well. So, Madam Chair, Vice Chair, and everyone here and at home, I very much look forward to being able to answer any questions that you may have. And that was 17 minutes and 30 seconds, everyone.
Thank you so much, Dr. Clark, and thank you for sharing your personal story. You know, it's a great reminder that this work is more than numbers, it's more than reports and data, it's people, and people we love, and I really appreciate you sharing. Thank you.
Thank you.
I'm going to open it up to commissioners, see what questions, comments we may have. I see Commissioner Larson, Commissioner Gordon, did I see you? Yep. Commissioner Gordon, Commissioner Robinson, Commissioner Chambers, Commissioner Contreras. Okay, Commissioner Larson.
Thank you so much. I'm going to do my preface by saying I'm the CEO of the Steinberg Institute, but I'm speaking as a commissioner. I think this report's really well done. I may have read every single FSP report that we've done so far, and this one's a really robust, really well done, and so I really want to, kudos to you and your team for doing it. I think I continue to be frustrated, not with anything you guys are doing, but with the lack of incarceration data. FSPs were created to reduce homelessness, incarceration, and hospitalization, and so the fact that we can't report on the reduced incarceration hurts my heart a little bit. I think also just like that thread of reading through all the reports and coming to this one, it frustrates me that we keep saying, like, the data's really bad, so we can't really tell a story. So my hope is that as a commission, as we go into this next phase with the identified priority populations that Prop 1 is intending us to focus on, and with so much of the BHSA going to FSPs, my hope is that we can really lean into that data quality issue. I just want to do a quick history lesson before I make my next comment, that FSPs were born out of AB 34 and AB 2034, which were focused on the SMI population who lived unsheltered. And so the fact that 56% of our FSP slots are going to kids who haven't been hospitalized or homeless, aren't SED, gives me pause. You know, children and youth, we definitely have a crisis. They have lots of needs, and they have a full entitlement of services through EPSDT. And so I'm worried that so many of our FSP services that were designed for our priority populations that were experiencing homelessness, incarceration, and hospitalization, that these services aren't going to those priority populations. So I appreciate your recommendation for more standardization and for the focus on the children's FSPs moving forward.
Thank you so much.
Thank you, Commissioner Larson. I feel like I have follow-up questions, but let's go to Commissioner Gordon, and then Commissioner Robinson, Commissioner Chambers, and then Commissioner Contreras.
Thank you for an excellent report. I just had two quick questions.
Sure.
Number one, you said DHCS is planning an overhaul of the DCR system so that you don't have to cobble together the information which you so artfully did. When might we expect that to be completed?
That's the million, billion, and trillion dollar question. We actually am not sure. So these announcements are fairly new, so we are waiting to see. I do want to state that overhauling a system is a big undertaking, and this is probably not a pivot that's going to be able to be made in 6 months. Or, you know, so we need to understand that it's going to be a process, but we have built our internal capacity here to continue to be able to tell a holistic story, hopefully, even now more with DOJ data and our Medi-Cal data, so that, yes, we want to get better data tools in the hands of providers. That is absolutely necessary, and we most certainly are supporting and pushing for that. We do plan to be able to still tell our story about FSPs, in fact, even richer form, without having to wait for that. So we see it as a tandem effort.
Yeah, and I was just going to say, if we, with our expertise in some other counties, might assist them, maybe we could speed it up and ask them for a few dollars to help us.
We'd be
do
happy
that.
to.
Okay. Second question, you talked about internships and widening the pipeline. Is HCI going to do that, or who is going to do that? Because I know here in Sacramento County, we're doing it ourselves because we're not seeing anybody jumping up to do it.
There are efforts. We feel that we could come to the table to support those and inform those better. I know that we're expecting more efforts in these areas. They are multifaceted and out of multiple departments, so I do want to say that. And we're learning more every single day. But we still see ways to improve them, and so that's our hope, is that we could go to that table and bring what we've learned and inform that.
Okay, and once again, thanks for your dedication to this work.
Thank you.
Thank you. I appreciate your presentation. Just back on slide 10, I just want to make sure I'm understanding the data. You say it says there was is that a 250,000 decrease in inpatient days? Okay.
Days, yeah.
And how many people did that represent? What group of people were we talking about?
So the actual count, I would have to email you the actual count. I'm
Or
not
is it, I mean,
sure. It's at
what would, like,
27.
on average, what was the average participants' decrease in their number of hospital days? That's what I'm trying to get at.
I see. I don't want to misspeak, so I really don't want to, but we have done that, and I can send it to you.
Okay. Thank you. It'd be good to know.
I just want to say I was impressed with your presentation, and I've been writing FSP programs, for a long time and committed. And I just am going to sound like a broken record, but like FSPs is one of the hardest interventions for clinicians to do. I mean, when I recruit people that want to leave county systems because of how hard it is, but they are the most dedicated folks. And so when I see the peer and paraprofessional supports in the workforce, what are you, and I know you mentioned about provider support, and I know that there's efforts by other departments, but I don't, and I think you had like suggestions on like what, like trainings and stuff that would support with their wellness, but is there anything outside of training that the clinicians and other people said that they would like to support them? Because I feel like workplace mental health in general for like, and I'm not perfect, but that's something I'm like very intentional with. And I believe the system needs to be in alignment with like creating government systems and county departments that focus on supporting like the workforce. I know they talk about other professions needing support, but I really, I mean, do you understand? I know you understand what I'm saying, but
Yeah.
like, do you have any thoughts around that? Because people really, those clinicians are really in the trenches, and they're the most dedicated as well. And that's just one. If you want to respond to that, then I have one more thing on performance management.
Absolutely. So when we wrote this, it was based on the recommendations to look into this area. Since then, we're hosting work groups with individuals, including peers and including counties that have more robust peer systems and services. And what we're doing is taking all of those learnings to develop a chapter of the toolkit that we will hand out. So those recommendations, we're in the listening session phase of that right
beautiful.
now, in the learning session phase, yeah. And so we hope to have that to circulate by this summer. We'll come back with those recommendations. We don't have them just yet for what that looks like in particular, but we feel confident that we'll be able to have those.
And I think that's amazing, because that could be really an opportunity for us as a commission to uplift and support of our counties and departments with taking that section and really, I don't know, taking it on a road show and really providing these counties with support with how to meet their workforce. And like you said, the peers, because, you know, it's just such a deficit. And then the performance management, I'm really excited to see how that RFA comes out, because I know that there's so much changes with Prop 1 and like the EBPs. It's just the fidelity to the model is, once again, it's going to cause a lot of pressure and on the clinicians to learn, to retain and recruit folks that can understand all the modalities of practice. How do you foresee a positive perspective on performance management and incentivizing and taking our RFAs to incentivize what's already happening with DHCS, because they are right, they're already having their performance. It's kind of simultaneous, right? But I think we can also, that's another opportunity for us to really take that on the road show too. Like, I don't know, this is giddy, but do you see what I'm talking about relative to performance management?
I
as well?
absolutely do. And so you
All right.
are correct in that we are not alone in the efforts in this area. We certainly are not. But we do believe that we have a unique voice, especially given the way that we approach learning, that we can still come to the table and help shape those. And that's what we're hoping to do, especially around the performance management. We have a particular history in technical assistance around performance management that we hope will be unique and very valued as those decisions are being made.
Thank you.
Thank you. Commissioner Tsai?
Thank you for the presentation. Thank you for also just bringing your whole self to your work. I think that's important. Data is something I'm very passionate about. That area of my organization directly reports to me because I think it's incredibly important. And I want to make a couple comments that some will say complicate issues. I would say kind of nuance issues in ways that hopefully are appropriate. And that's, you mentioned, I appreciate you mentioning kind of the incorporation of substance use. And when I look at these metrics, oftentimes we focus on things like service visits, readmissions. If you look at the National Quality Forum or NCQA or Washington Circle, there's a pattern to the metrics that we measure and how we define success. One of the things that I just want to add to our conversations and considerations here at the Commission with respect to data and metrics and substance use specifically, is that for some of those metrics, things like readmissions and service contacts are not a bad thing, right? So when people relapse, we actually want them to come back. And so I actually, when I talk about mental health data and substance use data, I think it's important that we kind of distinguish between, good metrics that are good to be high and metrics that are actually bad to be high, right? Because I think there are sometimes the same metric could actually be interpreted differently. And so I just want to kind of highlight that as we move forward in this more comprehensive world that will get more nuanced.
You are 100% correct in that, and I just want to say I'm excited to get the data to hopefully be able to unpack that and see if there's subgroups of communities where we can identify, because you are 100% correct in that. And interesting, in the report, you will see that there's also differences by counties. So in some counties, we do see an increase in services after being connected to an FSP, which would be indicative of them actually finally getting access, right? Which is great. And then in some counties we see, or majority of counties, we see a drop, which might be indicative of the fact that now they're getting more preventative care. But we can't really unpack that until we have our Medi-Cal data and be able to look further into what that might be. But you're absolutely correct.
Thank you. And I sincerely apologize. I skipped over Commissioner Contreras.
Totally cool. Thank you so much, Kaylee, and thank you so much for sharing Marnette's memory with us, too.
Thank you.
That was very special. I have questions about the providers as well. Did the study give us an opportunity to sort of understand the provider landscape? Like, what do these providers look like?
Yeah, so we do have a lot of information about providers. We did a statewide survey, actually, of providers, and that is something that we can look at presenting in a different format to look specifically at a landscape of providers. We did more of that analysis internally to help inform how we would interpret and produce the report results. Mostly because the report was also already very long, but we do have that, and if that's a value, we're more than happy to put that together and share that. It's probably something that we can look at doing more robustly and exhaustively as a standalone brief or a piece of that nature.
Yeah, I think that would be helpful just to see, what level of support maybe some providers need, right? The other question I have is around the money that we pay providers. So the report says like, hey, it's very hard for them to bill, right? And to braid that funding. But I'm wondering if we've ever thought about looking at it from the perspective if they were able to do that perfectly. Would those rates even be enough for them to meet a lot of the recommendations that are already in this report, which is, the workforce development, less stress, FSP, we like to say it's a whatever it takes approach, right? Which takes a lot. So I'm just wondering, if we've looked at it from that angle.
So we hear extensively from our providers that there's concerns in that area, and quite frankly, in order for us to do that analysis, that's step 2 of first, let's all get on the same page to ensure that we are handling the financials in the building the way that is intended by DHCS. Currently, what we see is a disconnect there, and DHCS has done extensive trainings in this area, but there remains a disconnect in a lot of questions. And so first and foremost, we want to see that capacity built. And then when we feel that that's, we can then take a look to learn more to see, okay, where are the gaps that still exist? We have not done that analysis now, I will tell you that we have not done that yet.
Got it. I just.
Go ahead, Melissa.
I
This
was
is
just
my
gonna-
boss.
No. I was just going to add that we've heard specific technical assistance requests from providers in that area.
Yeah.
And so, the hope is that things like BH Connect can support counties' ability to do that and incentivizes them to draw down Medi-Cal dollars. But like Callie said, we haven't done a full analysis.
Yeah, I just worry that even with the technical assistance, do providers have the resources to build the capacity to keep up with it, right? It's a lot of work. And I suspect the answer is no.
Yeah,
right?
it's a very,
Yeah.
Commissioner Rowlett can let you know, but it's very clearly an issue and a concern.
Yeah, so I just think it's important to highlight that even the rates themselves, are not sufficient. And then my last question is around metrics, which is, are housing outcomes part of the metrics?
So we have housing data for us currently is very difficult. We are able to tell a housing story at all because we bring in a number of different touch points across data sets. We are looking for ways to have more robust housing data. However, thankfully, we are able to bring a number of those sources together, but it needs to be much more available if we're going to tell a coherent story, especially moving forward with the data requirements under Prop 1. We need to be able to tell a more holistic housing story. And so that's definitely one of the necessary components of this data overhaul.
Yeah, I think that's really important because we're leveraging a lot of scattered site housing, right? And that means that we're very dependent on the FSP services. So just to see from that perspective, you know, how impactful is that being for housing, I think would be great. Thank you so much, really appreciate it.
Thank you.
Thank you for those comments. Commissioner Cross, please.
All of the commissioners have been really good at like answering the questions that are going on in my head. So I'd like to speak with you privately when things pop into my head, because nothing is going on right here, and like right now, because you guys are, you know, you're burning a fire in me, so I'm hearing and listening. But I also just wanted to say I'm sorry for your loss.
Thank you.
You know, but yeah, you too, your reports, it was amazing. I'm learning. I feel like I'm just really excited about everything. So thank you.
Thank you so much. And whenever you want, I'm here.
Thanks again for the report. A few of us got to preview the report, make some recommendations. I'm going to suggest that in 2026 that you consider being a bit more of a disruptive innovator. And that is not a bad thing, but I think that we all know that, for example, as if you're a data repository and you're not required to really be accountable for the condition of the data, you're a repository in name only, and the data is not usable. And so one of the sort of provocative, innovative things that come to mind from reading your report, thank you very much, is why couldn't we be the data repository? Why couldn't we be the place where FSP data comes? Why shouldn't we suggest that? And why shouldn't you suggest that to the commission? That's something for you to think about, because I've heard for over, Karen Larson can tell me better than anybody else, how many years I've heard the data at DHCS is a dumpster fire. And so I'm tired of hearing about that. It's over. It's a new day. Let's get useful data and let's not repeat the mistakes of the past. So that's one thing that your report provoked me to think about. We should take that role on. And we should be the innovators that really say, hey, state government didn't work so well here. Yeah, this is a great initiative, it's a great idea, but let somebody else gather the data for you and then get it back to people efficiently and quickly. That takes me to my second point. You described a relationship in Sacramento and Nevada. I assume that's the Healthy Brains Global Initiative folks. And so one of the things that I think Commissioner Tsai caused me to think about is that they synthesize data collection into a series of very, very discrete but sort of simple questions from the perspective of the end user or the consumer or their family. And to talk about that more in your report and bring back more about that and why you said that's successful, that'd be really interesting. And then lastly, I too was touched by what you shared. I lost my son due to issues associated with affective disorder and substance use. And what I know is the stories of the people matter. And when I saw, again, the brief slide that was depicted by the organization that was really highlighting the needs of the LGBTQ plus community, that was powerful. So incorporating some of that village into your next presentation, I think would be very helpful. And in bringing, I love the voice of people who are utilizing FSP services and who really are, that's the safety net services. And I love hearing their voices, bringing them here to be a part of that, albeit through that sort of virtual platform or even in person. I think again strengthens that report in 2026 and really does move you into what I think just spontaneously where you should be, the disruptive innovators for the state of California around FSPs.
Thank you so much. I hear that, and that's a great license for me. Thank you.
Okay, great. Thank you, Commissioner. Oh, yes, Commissioner Designee.
At the risk of sounding like, I don't know, something I told you so, or the old person in the room, the 3 executive directors ago, the executive director of the commission requested resources of the legislature to take over the data collection, to increase and expand, using the same argument. At that time, the person who is now the director of the Department of Healthcare Services was the budget staff person, and she shot it down. So it's a heavy lift, it's a Sisyphean task, but I do believe that the commission does have the capacity to do more with the data than the department, in spite of the fact that it's been challenging to get them to give it up.
Well, there's definitely a lot more on DHCS's plate now, so maybe they can reconsider. Mariani, can we open it up for public comment, please?
Yes. We do not have any public comment in the room. We do have 2 public comments online. Our first comment is from Steve. Your line is open.
Hello, I'm Steve McNally from Orange County, speaking as an individual. And I apologize for speaking so much today. If there was chat available, I would just said thank you very much to the presenter. I just want her to know that she's got a fan club, and I'm going to be the president in 92627, Costa Mesa. You did so many things that I appreciate in a presentation. One is you modeled us eliminating self-stigma. You provided a lot of detail at a high level, and also the detail of the data in and how difficult it is for the people working in the field to provide it, the interruptions, and then the can state, I think it's social services, just how screwy it all is and how old it is as far as systems. I'm a big believer in the open data portal. I'm not really sure if you've used it very much. It's not the de-identified data. I mean, it's all de-identified, but if someone would look at that, and maybe that could be you or someone else, I haven't never found someone who really wanted to look at it, to bring county level data, because it's basically 600 data sets at Department of Healthcare Services, and you can pull down a lot of stuff that you did show in your report as an interim step to get the communities involved. And part of the data question is you have to want to do it. You have to be motivated to do it. And in our county, we estimated at one point $90 million to comply with reporting for Prop 1 to put all of the different areas together. I don't know I've never heard DHCS really talk about how they're going to get the data system up and running. I'm not a data person, but I appreciate using data and also appreciate Commissioner Tsai's discussion. My son goes to a CSU voluntarily, so when he readmits, he's not a problem. He just finds it as a safe place for his own recovery. And I'll just leave it. I went to a Snowflake presentation, if any of you are aware of that, the data cloud. And I thought maybe the open data portal was built on that, but they wouldn't release who their clients are. But it's a great way to coordinate and make the data easily available to everyone in the state to build more champions, because I haven't found a champion when I go to stakeholder meetings at the state for Prop 1 and all the various Department of Healthcare Service stakeholder meetings. First, they're mostly presentations, very little conversation. I just love how this commission is now talking more intentionally about getting working together and showing more enthusiasm. So thank you very much, and have a great day.
Thanks, Steve.
Thank you. Our next public comment is from Jay. Your line is open.
Hi, Madam Chair and Commission members. My name is Jay. You've heard me speak yesterday on some of the issues representing the California Behavioral Health Association, CBHA. We wanted to thank the presenters for their wonderful report and how comprehensive it was on full service partnerships. We just want to express how critical it is for the Commission and legislature to enhance the fidelity of FSPs as Proposition 1 rolls out. We'd like to note that the Commission's 2024 report on FSPs noted complexities in eligibility requirements and administrative burdens that are stemming from the ongoing billing changes with CalAIM, BH Connect, and other initiatives. Full service partnerships are an effective intervention for stabilizing individuals, especially those with severe mental illness and complex social needs. But we also need to make sure that providers are given adequate resources and guidelines to ensure effective implementation at the provider level. We want to ensure that Californians at the highest risk of crisis, including individuals who have experienced homelessness, housing insecurity, repeated hospitalization, and justice system involvement, are able to access easily the services that they need, and we encourage the Commission to support any recommendations to the legislature that expand access to full service partnerships and adequately supports providers in its implementation. Thank you.
Thank you. That was our last public comment.
Thank you. Thanks again for the presentation. At this point, Commissioners, I'll entertain a motion that the Commission adopt the 2025 Full Service Partnership Report to the legislature.
So moved.
Second.
Thank you, Vice Chair Roulette. Sandra?
Thank you. Commissioner Bear,
Yes.
Commissioner Bernick, Commissioner Bontrager,
Aye.
Commissioner Brown,
Aye.
Commissioner Bunch, Commissioner Callan,
Aye.
Commissioner Carnevale,
Aye.
Commissioner Chambers,
Aye.
Commissioner Contreras,
Aye.
Commissioner Designee Swartz, Commissioner Cross,
Aye.
Commissioner Gordon,
Aye.
Commissioner Designee Polmano. Abstain, okay. Commissioner Larson,
Aye.
Commissioner Madrigal-Weiss,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Southard, Commissioner Sy,
Aye.
Vice Chair Roulette,
Aye.
Chair Alvarez.
Aye.
Motion passes.
Thank you. Thank you again.